Welcome to today's seminar titled Injury Data and Surveillance, What Are You Looking For?, which is the fifth of the Surveillance Advances seminar series, co-hosted by the Public Health Agency of Canada and the National Collaborating Centers for Infectious Diseases, or NCCID. My name is Luisa Arroyave. I'm a postdoctoral fellow at NCCID. I will be your moderator today, along with Elisa Young, who is a senior epidemiologist in the Data Surveillance and Foresight branch of the Public Health Agency of Canada. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning programs and policies related to infectious diseases. We are incredibly pleased to be co-hosting this series with the agency. I would like to acknowledge that NCCID is hosted at the University of Manitoba on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land. We recognize that these and other treaties have been implemented as part of the process of colonization, intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. Okay, before we dive into today's seminar, there are a few housekeeping items I would like to mention. A recording of this seminar and presentation slides will be available shortly after the seminar on the NCCID website, which is nccid.ca under webcasts. If you have technical problems with Zoom during this seminar, please email us to nccid@umanitoba.ca. Also, you can send us topic-related questions to the QA, and we will try to address as many as possible in the discussion period after the presentation. Also, you can like any of the other questions to push them in priority. We would also like to know that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for Professional Development Award for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation after the seminar. Over to you, Elisa.
Thank you, Luisa, for going over some key important housekeeping items. Welcome, everyone, and thank you for joining us today. Bienvenue à tous et merci d'être parmi nous aujourd'hui. While today's seminar will be delivered in English, we welcome everyone to pose their questions in their official language of choice in either English or French. Before we jump into things, I would like to take the time to acknowledge the land where I live and work. I live in Winnipeg, Manitoba, located on Treaty 1 territory, the traditional lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and is also known as the homeland of the Métis Nation. Today, we will have participants joining us from coast to coast to coast, with today's presenter joining us from, spoiler alert, from the East Coast. It's important to acknowledge the land where you all join us from, which represent the lived experiences of many Indigenous people, all with their own unique health story. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of the determinants of health and disease in populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar series, we would like to note that the use of the word surveillance is referenced to refer to the assessment of and response to public health threats as a core function of our public health system. And lastly, the seminar series is not just about the speakers and organizers, it's about you, the audience. Your active participation, questions, and perspectives are vital to the success of this series. We encourage you to engage in discussion, ask questions, share your thoughts, and foster collaborations that can lead to improvements in public health surveillance.
With excitement, I would like to introduce and welcome our speaker today's seminar, Dr. Richard Ruiz. He is the Provincial Injury Prevention Specialist for Trauma NB with over a decade of experience. As injury prevention specialist, Dr. such as the Provincial Concussion Harmonization Project and the Find and Balance NB program. In addition, he has experience in leading collaborative efforts with stakeholders across Canada as the chair for the Atlantic Collaborative on Injury Prevention and co-chair of the Canadian Collaborating Centers for Injury Prevention. Welcome, Dr. Lewis. We are really happy to have you today with us, and we are excited to learn about your experience and knowledge in injury surveillance. Thank you so much, and the floor is yours.
Thank you very much for that beautiful introduction. With that, what I will do, yes, I will share my screen in order to start my presentation. So with that, here we go. So essentially, today, I'd love to be able to talk to all of you about injury data surveillance, and more specifically, what are we looking for? As an injury prevention specialist in New Brunswick, me and my colleagues from across Canada are always looking for relevant data in order to help with our decision-making process. And today I hope to provide you with a bit more information about how that happens. Before we get there, I'd love to be able to mention a few conflicts of interest. So just to mention, I'm current chair of the board for the Atlantic Collaborative on Injury Prevention. And I'm also the co-chair of the board for the Canadian Collaborating Centers on Injury Prevention. I also wear different other hats, but those are two and more specific that I'd like to mention. So today, learning objectives. Well, number one, I'd love to be able to help you understand that injury prevention as an integral part of a comprehensive public health approach. And number two, helping you recognize the importance of collaborating with primary knowledge users like myself around actionable data. So when we're talking about understanding that injury prevention is an integral part of a public health approach, it's to understand that, when we're talking about reducing the demand for healthcare services, that's exactly what we're referring to, whether we're talking specifically about communicable diseases and trying to reduce the demand on our healthcare services due to pandemic, for example, environmental pathogens and pollutants. Each province has an array of inspectors going into restaurants, making sure that the food is okay, that the water that we drink is okay, and obviously even going to the beach, that we're not facing algae blooms and the rest. Chronic disease prevention, well known, whether we're referring to diabetes, cancer care, hypertension, and everything in between, obesity. So really well known, well funded. Intentional injury prevention, a sphere that's recently getting more and more attention with regards to mental health and addictions. And when we're looking specifically at violence prevention or self-harm, that's that sphere of activity around intentional injury prevention. The last one being unintentional injury prevention, and that's where I work in collaboration with WorkSafe New Brunswick, who obviously look after work safety in the workplace setting, while I look after safety in the community setting. But as you can imagine, this is a collaborative approach, a collaborative effort in order to really try to provide that support to our emergency departments and primary care providers in order to, again, address overcrowding, reduce the demand for primary care provider services, and the rest. So what are some of the leading concerns for primary knowledge users like myself? Well, injury prevention specialists from across Canada are faced with similar challenges, right? Limited visibility being the first one. Not everybody within government or researchers, epidemiologists, and data analysts know that we exist, essentially. Or what do we do on a day-to-day basis? So being able to raise awareness about the availability of injury prevention specialists is one first step, whether it's with politicians, like I mentioned earlier, researchers, data analysts, and others. That's the first challenge. The second one, looking at doing as much as we can with limited available resources. And this is where the importance of prioritizing interventions in order to affect the greatest change on the ground comes. And essentially, a question that gets asked very frequently is, are we able to deliver a sustainable interventions? Because having a great program that works well for 1 or 2 years is one thing, but ensuring that that same program is sustainable is even more important in order to ensure long-lasting impact with regards to injury prevention, regardless of the mechanism of injury. Last but not least, looking at the funding ratio between research and implementation of best practice or best interventions. So essentially, the reflex is to ask ourselves, are we spending too much time, too much resources on injury prevention research versus implementing best practice? Obviously, we want to use data to help drive our decision-making process, but we can't be paralyzed with regards to focusing exclusively on data before acting. So with that, you might ask, I'd love to be able to ask all of you, what do you think is the leading cause of injury leading to hospitalization? You might think, and here I encourage you to put your answers in the chat, please. I'll give you, I'd say 30 seconds, 1 minute to provide to share those answers. So with that, I could sing all of you the Jeopardy song, but I'll save all of you with that. Options could be sports-related injuries, motor vehicle-related injuries, poisonings, drownings, burns. There's a myriad of ways that people end up in emergency departments. So I'll give you again a couple of more seconds in order to get those answers. I see alcohol. I see a lot of falls. Alcohol, trip and falls. Okay. Well, that's good to see. What I'll wait for one more. Seems like we're leaning towards falls, a couple of alcohol and falls. Okay, well that's good. Trip and falls. Okay, good. So essentially, let's look at the data together. Real quick, that's the type of information that I look at. Essentially, for that is the discharge abstract database. Trauma in New Brunswick, we're lucky enough to have a data analyst and an epidemiologist part of the team. And along with myself, we have regular meetings to discuss data. I know that I'm lucky enough to have that type of working relationship. But with that, it provides me with data like this, where, as you can imagine, data from the discharge abstract database is mainly in an Excel format. But to take that information and to translate it into something that anybody without a healthcare background can actually follow. So essentially, the big blue line that you see here is our falls. And the orange one being poisoning. So for children 0 to 4-year-old in New Brunswick, we're really looking at falls being the leading cause of injury. 5 to 9, falls. 10 to 14, still falls. And again, here we're looking at data spanning from 2006 all the way to 2018. 25 to 34, still falls, with the second one being motor vehicle related injuries and the third one being off-road related injuries. So whether here, 25 to 34, so same thing here, falls. I mean, like you can clearly see, falls has been such an issue in that age group that will need to change the scale in order to provide a clearer sense so that we can compare with the even older age groups. So 65 to 74. So here we have our scale to 6,000 instead of here we have it at 200. So again, 65 to 74 falls, and falls. The tiny green one down here is our motor vehicle related injuries. So it's pretty clear that using this data, it really provides that clarity about what is the leading cause of injury that leads patients to be admitted to the hospital. So for myself, that provided me with a clear direction about where I should be spending most of my time and resources in order to address the leading cause of injury, and more specifically, falls in older adults. But beyond that, knowing, okay, what type of injury is but one answer. Another question that I had was, okay, when do they occur? Essentially, here again, looking at that data per quarter, we can see that falls in our children 0 to 14 down here, falls all age groups up here, falls in older adults 65 and over right here. You can clearly see that there's a trend happening. But what's interesting for me is seeing that there's spikes happening at regular intervals, mainly to give me a better idea of when do we see our larger numbers of falls. With that information, just like you might have heard over the past few weeks and months about overcrowding in emergency departments across Canada and attributing those numbers to respiratory illnesses, well, the same happens with falls, where we do tend to see those larger numbers during the months between January and March. So in order to raise awareness about the fact that it's not just respiratory illnesses, in order to prepare our emergency department for that oncoming increase of cases, that's where I use that type of data. Beyond that, like I mentioned earlier, you did see an increased trend, but really how big was that trend was something that I really wanted to have a better sense of. So since we already know the rate of falls per age group, we were able, well, I was able to calculate using Statistics Canada population projections for New Brunswick, able to combine those two data sets in order to provide a clearer sense of what's to come. Where, again, you can see in 2010, we had about 2,000 cases of falls among older adults in New Brunswick, where in 2020, we looked at about 2,800. Just a little clarification, the blue zone being our older adults 64 to 65 to 84, our red zone being 60, the blue being 65 to 74, the red being 75 to 84, and the green being 85 plus. So knowing those rates, we're able to calculate and come to a situation where in 2030, we're expecting to see about 4,000 cases, and by 2040, well over 5,000 cases. So with that type of exercise, we're able to use the same type of language that was used during COVID with regards to trying to flatten the curve, right? Trying to, again, reduce the demand for healthcare services, knowing fully well what's to come if nothing is being done to change the status quo. Again, very useful in order to get traction from those without a healthcare background or who aren't as steeped into the injury prevention world. Another really important form of data information to be able to share is the dollar amount associated with the leading causes of injury. And this is an exercise that a project that we've done through ACIP, the Atlantic Collaborative on Injury Prevention, in collaboration with Parachute Canada, which received federal funding in order to provide all stakeholders across Canada with a Canadian cost of injury report. However, that report did not provide a provincial breakdown. So together, through ACIP, our Atlantic partners were able to pool our resources and partner with the BC Injury Research and Prevention Unit in order to provide us with that provincial breakdown. And in turn, taking that data and plotting it into very simple infographics that our partners in all 4 Atlantic provinces could use in order to make arguments during presentations like this one, or with conversations with politicians, or with funders. So here on one page, you can clearly see that falls is an issue for 0 to 14, 25 to 64, and 65 and over. Only when we're looking at our youth 15 to 24 that we see a transport-related incidents playing a large role, and suicide and self-harm. But not too far behind, we still have falls playing a major role. Now, with that, that really helps focus our attention, like I mentioned, on the leading cause of injury, because as you might know, looking at the media, you might be tempted to say, e-bike related injuries, or Pokemon Go was a thing one year. Swallowing Tide Pods, imagine that, was even a thing one year. So really, knowing fully well that the hot button issues might pop up each once in a while, it's okay, but to really use data to focus our attention on what should be addressed with limited resources. So with that, when we're talking about advancing the practice of injury surveillance, a few recommendations for data analysts and researchers essentially is to, number one, reach out to your provincial Department of Public Health. Each province has a responsibility to look after public health, and in each Department of Public Health should have a person dedicated to injury prevention. Just like with COVID, like I mentioned earlier, there was one person leading the effort, even though that one person wasn't in charge with every aspect of COVID response. At least that person was well aware about what was happening on the ground and what would be next moved according to a well-defined strategic plan. So here, when we're talking about reaching out to provincial Department of Public Health, is to help provide that supporting information, supporting data to help with the development of that public health strategic plan, according to, again, predictable and measurable and reliable metrics. The next piece is reaching out to our injury prevention specialists like myself. So again, this is an extension of the first one, knowing that there's a great need of collaboration in order to support the implementation of effective interventions. So as you can imagine, whether we're talking about falls prevention in older adults, concussion assessment and evaluation and management, or everything in between, being able to gauge the effectiveness of the different type of interventions being put in place in order to, again, reducing the demand for acute care services is very important. Knowing that research in itself is interesting for many reasons, but really having information that's readily usable is even more important. And that's why I talk about the third point, the importance of focusing on providing actionable data. Like I mentioned, yes, there's different activities, different interventions happening, but what's important is to provide injury prevention specialists and in the other fields, preventive health fields, with data that's going to shape our decision making. What is going to actually modify what happens on the ground? Having, for example, a difference in fall rates in one regions of the province changing by 1% number isn't really going to change what I do on the ground. However, if, for example, falls in children 0 to 14 eclipses falls in older adults for some reason in one region of the province due to weather conditions, for example, well, that's definitely something that would be significant enough for me to follow up in order to understand what's happening in that region and to implement interventions to, again, bring it back to what we feel comfortable with. So those are three recommendations for our data analysts and researchers, but there's also recommendations for healthcare professionals. And here I could also add our caregivers to the mix. So for this group, recognizing the importance of accurate charting. Now, a little bit less so for caregivers, but here mainly for our healthcare professionals, providing invaluable information to help assess injury prevention concerns is key. For example, when we're referring to head injuries, whether it's being put in the medical chart as a concussion versus a head injury not otherwise specified makes a big difference with regards to my ability to assess what's happening on the ground. Having a clear, clearly marked in the medical record that it was a concussion, it makes it a lot easier. Same goes with the type of fracture or the type of follow-up treatment that's being provided to that specific patient. Is all useful information in order to, again, help allocate necessary resources to address specific concerns. The next one being enhancing the level of participation in research studies. And again, not all research is created equal, but really knowing fully well that certain research studies are really important for primary knowledge users like myself in order to really change our interventions or modify our interventions that are happening on the ground. So really obtaining timely feedback is key here. Participation is one aspect, but if at the end of the day, you're not able to provide those answers in a timely manner, that really influences the strength of the different research studies. One last piece, looking at sharing regional injury data to shape clinical practice. So obviously here, it's not direct participation in a research study. Essentially, it's being an advocate, being a champion in order to share that injury data with colleagues, other healthcare professionals, so that they in turn understand the scope and scale of specific concerns that they're being faced with. And in addition, the different interventions that are being made readily available to them in order to address them. So essentially understanding that whether you're a researcher, you're a healthcare professional, caregiver, older adult looking for answers, we all have a role to play when we're talking about helping to reduce injuries. And with that, just want to say a big thanks and opening up this session for any questions that members might have. Before that, I think I'll pass it to Elisa.
Yeah.
In order to say a few words at the end.
Great. Thank you so much, Dr. Lewis, for your presentation on injury surveillance. We will now have a discussion period. We invite everyone to ask any questions you have for Dr. Lewis in the Q&A tab. Everyone is welcome to participate in the conversation. Please feel free to, again, use your choice of the official languages, either English or French. We'll try to get to as many questions as possible, but we may not get to all of them. So while I wait for some of those questions to kind of percolate into the chat, Dr. Lewis, I do have some questions maybe we can kind of start with.
Sure.
From your experience, how can we strengthen, relationships and collaboration between those working in surveillance, healthcare, primary knowledge users, and researchers and other stakeholders to really enhance injury-based surveillance? How do you see some of these collaborations best being forged?
Well, essentially, collaboration starts with a conversation, right? It's sending that email. It's really, even though you might not feel comfortable doing it, but really reaching out, right? Oftentimes you might not get an answer right away because in different provinces, that person might be different. That's why if you're really looking for that injury prevention specialist or that injury prevention person in your own province, I would strongly encourage you to reach out to Parachute Canada or directly to myself as co-chair of the Canadian Collaborating Centers on Injury Prevention. It'd be my pleasure to connect you with that person. Because ultimately, like I mentioned, it starts with the email, then it goes to a conversation about what that primary knowledge user is looking for so that you can together look for what's most important for them. Different, like I mentioned earlier, different provinces might have different priorities when we're referring to injury prevention. So knowing that you're having that buy-in from injury prevention specialists in your province would really provide that reassurance that you're heading in the right direction and spending your, again, limited resources happens not just with our field, but I'm sure it happens with researchers and data analysts too. So making sure that you're using your time and your funds and maximizing its usefulness. Starts with that.
Yeah. Thank you. Wonderful. I guess the follow-up question is that, from your experience, do you have some examples of successful collaborations and partnerships while working in New Brunswick between researchers or other collaborators to really understand injury-based surveillance a little bit better?
Well, like I mentioned earlier, I have what I call my data team meetings internally. But what we also try to do during our data team meetings, me, our epidemiologists, and our data analysts, is to start inviting external partners, right? Partners like WorkSafe, our New Brunswick Health Council, our New Brunswick Medical Society, and other partners. So yes, it's great that we're doing, we're collaborating with regards to injury prevention specialists and our data analysts and epidemiologists, but it's always important to reach out to others to be sure that we're also answering questions, concerns that other stakeholders might have. That way we have even more people on the same page, being able to push that heavy rock up the hill together.
Excellent. As we were speaking, I think we've got a few warmed up folks. We've got some questions in the Q&A pod. So maybe I'll get to the first question here, if you're okay with that, Dr. Lewis. Hi, thanks for the presentation. I work on injury surveillance at FAC. We have several surveillance products related to falls, such as reports, data blog. Our analyses have shown that the mortality rate due to falls among older adults just keeps rising. What reasons do you think behind this as a professional working in the injury prevention fields?
Very great question. I hope that I would be able to provide you with an answer. Obviously, frailty is one aspect that I might mention, right? Where with an older population of, falls occur at all ages, but with the older population, we know that compared to our younger age groups, you bounce back a lot slower. So that's what I would mention. But beyond that, this would be a great question for researchers, for example, right? In order to understand the mechanisms behind it. Saying frailty is just one word, but having that meat behind it would be pretty interesting in order to, again, provide that information back to our primary care providers and other healthcare professionals so that they can in turn do what's best, right? We have an idea. It starts with an idea, but it really continues with collaboration with researchers like yourselves in order to address them. And like I mentioned at the beginning, with regards to needing additional resources in order to affect change, that's exactly an example of collaboration, because as you can imagine, when I was referring to the different bubbles, communicable disease, well-funded, well-known, environmental hazards, chronic disease, and intentional injury prevention lately getting the attention that they truly need. The last piece is injury prevention. And right now, it's finding partners in order to help make those arguments, in order to at least get, I would say, 5% of public health spending, where the rest, we're not even close to that 5% right now. The rest of the 95% goes to the other bubbles. So it's really making a space, making our argument for the importance of integrating injury prevention within the larger public health approach. Does New Brunswick have knackers? Quick answer, nope. Unfortunately, we do not. But I'd always keep an eye open to give me an idea about what's happening in our EDs. Like I mentioned, being part of Trauma New Brunswick, we also have our own trauma registry that I look at in order to get a better sense of what's happening in emergency departments in New Brunswick. But simple answer, no, we do not participate in those, unfortunately. I work in injury prevention, public health, two things. Seems to be a lag with the data. Yes, lag with the data. Yeah. And that's something that we're looking at resolving. Again, with limited resources, data capture is difficult. But lately, it's not all doom and gloom. We did manage to get additional resources in order to help with that aspect, in order to get a bit more timely data. And even getting timely data is one aspect, because converting that timely data in usable data that I can in turn show to those without, epidemiology background or data analyst background, it takes a little bit of time. So there's that lag. So there's the lag for me to get the data. Then there's a lag for me to create a simple form, whether it's an infographic or bar charts, simple bar charts, or anything else that can be shown to others in order to get even more resources, to do even more on the ground, to have even more change, to reduce even more the demand for our healthcare services. So it's an ongoing thing that really never ends. It'd be nice that people would stay safe, but I'm sure that's wishful thinking. But ultimately, what we could look forward to is to make an impact, right? Even though we're not going to bring it to zero, or it'd be great to be able to bring it close to, right? Or to a level that's manageable. Just like with COVID, the goal wasn't to get to zero COVID cases, but really to get to a place where we have manageable number of cases, where now we're talking about we're not talking about an epidemic, we're just talking about a different phase, and trying to do as much as we can with our available healthcare services. So the same applies, especially when we're talking about falls in older adults. operation room time is very limited. Here in New Brunswick, for example, we try to answer those concerns with providing operation room time in off hours, whether weekends or nights, in order to reduce the number of older adults needing to wait on our wait list longer than 1 year for hip fracture surgeries, for example. So knowing all that data, we can approach provincial government in order to reassure them that the use of those resources to reduce the wait list times is a good use of resources. But knowing fully well that that's a downstream approach, we also need to consider that upstream approach to reduce the number of new people being added to that waiting list, right? So that's where together, both the surgeons on the downstream and people like myself on the upstream together within that strategic plan to address falls in older adults, we can make that difference. But at the end of the day, that upstream approach takes a little bit of time in order to really have measurable differences. Starts with behavior change, then hopefully we can see some outcome changes following that, but it takes a little bit of time before we see those measurements.
Thank you. We've got one more question also in the Q&A as well, Dr. Lewis. Do you have ideas about how we could get more detailed information about the cases of injury requiring hospital treatments, such as specific activities or the use of specific products, at a time when there's a great concern over reducing administrative burden on healthcare workers? Well, it's good to know how many injuries are occurring. Prevention ultimately requires knowing the causes of those injuries.
So that really great question. And that falls again on the importance of accurate charting, right? So if in the medical record it's not there, well, then our our analysts or our data people in our regional hospitals can't really provide me with that data in our database, right? So obviously that puts more of a pressure on myself to do follow-up work, whether it's to do a survey with patients directly themselves, to do a focus group, to find other means in order to get those answers. So you're correct with regards to what's available versus what's really needed. So right now, again, the priority is to get a really clear understanding on what are the leading causes, where do they occur, who's our target group. So we're at that phase. Knowing the mechanism, how did they fall? Well, again, I shouldn't say that it's all doom and gloom. Even looking at our DAD data, looking at ICD-10, scores, the way that it's being presented, I can look at that data and see, okay, falls in older adults, where were they occurring? Were they falling from the toilet, falling down stairs, falling just slip and trips on the same surface, falls on icy surfaces? So I do have that data that I do play with. But if I want to go beyond that, that's where, like I mentioned, the surveys and the focus groups come into play. But really good question.
I think we've got time for a few more questions that I've also just popped into the chat as well. I see someone shared a Canada's Consumer Product Safety Program, so thank you for sharing that. That's excellent. We're seeing some knowledge sharing of products. The other question that came into the chat, Dr. Lewis, is what data sources feed into your trauma registry that you had mentioned?
So for our trauma registry, what we have is an inclusion criteria that looks at CTAS score. And again, I can go into the details. It's really looking at those more severely injured patients that get included in our trauma registry. So again, it's just a subset of what we see in our emergency departments. So again, that's why I always like to look at NACRS, even though it's in other provinces, to give me a more complete look at what's happening. So again, with the different data sources, it's almost like taking pictures of the same object, but through different angles, right? So this angle will provide me with a great front view, a side view with this other data source, a back view of the object with a different one. So that's how I use the different data sources. And again, with the support from my epidemiologist to help navigate this whole thing was really key, right? Because obviously my expertise is with regards to implementation and sustaining best interventions to address injuries, but together with our data analysts and our epi, I mean, we're doing amazing work. So that's the type of stuff that I'd hope to have encourage you to implement in your own province in order to really maximize the use of those limited resources. If there's any interest in injury, poisoning, yeah. So yeah, this is a good mention. Poisonings, right? Very well, there's a network, there's toll-free numbers across Canada now in order to have access to support if you're concerned about poisonings. And there's a Canadian concussion network. There's activity happening. But when we're talking about the leading cause of injury being falls in older adults, there's no Canadian falls network, for example, right? There's a Canadian frailty network. I know that osteoporosis does great work with regards to reducing fractures in older adults, but reducing fractures versus reducing falls are two different things. So that's an example of needing national support with funding in order to really be able to address that specific issue collaboratively across Canada with the help of my colleagues. One thing that we've done, since we're talking about what's happening, is through the Canadian Collaborating Centers on Injury Prevention in partnership with Parachute Canada. We did create the Canadian Collaborative on Falls Prevention in order to get stakeholders from across Canada to start talking to each other. Well, I say start, to continue to talk to each other between our national falls prevention conferences. So instead of waiting till the next one, to continue with ongoing conversations and to see what can be done at the national level together. So this could be another opportunity for researchers to reach out to one of us to get a better understanding about what's happening at the national level. If ever you'd be interested in getting more information, it'd be my pleasure if ever you feel like sending me a quick email to connect you with the people leading that collaboration.
Wonderful, thank you. And we do have, I believe, maybe time for maybe 2 more questions, if that's okay. One just came in about maybe a bit more technical in nature, but have you done any validation work on presenting complaint reason for visit using DAD data for trauma admissions?
Validation. The simple answer, nope. Again, I wish we could, but ultimately, when we're dealing with limited capacity, having actionable data is what I'm looking for. Validation work would be great to be able to do to be done, but again, it's just trying to weigh what's absolutely necessary at the time versus what would be interesting and great to know, right? So if there's any interest, here you go, in order to help do that type of work, it'd be my pleasure to connect with anyone out there in order to have that follow-up conversation. But yeah, very, very important, very good question.
And we've got one more, again, maybe technical in nature, but what kind of surveys have you done? Are there any challenges with data collection and analysis?
Surveys, usually what we do is we keep it small enough in order to get, again, actionable data. right? Having the larger scale, the larger scope and scale surveys, okay, but really it demands a lot of time and resources that we don't have in order to make those happen. So really what we are doing is, again, creating simple surveys with simple enough language that our responders can answer in a timely manner. And that's the most important piece. Having large surveys are great, but we've, with the years, understood that though the length of the surveys are often a barrier to getting answers. So to really keep it small, our philosophy is to have more smaller ones and keep that engagement with the public than to have one large one and burn them out and then needing to take that much more time before re-engaging with the public. So really that's the way that we proceed.
I think that was the final question in the Q&A, but we do have one question here from your fellow moderators as well. But, you know, with an interest of, you know, seeing sometimes there were peaks in falls, Dr. Lewis, among certain age groups in the data. Have you sort of explored any sort of seasonality related to these falls? Like perhaps, you know, we live in a winter climate. I'm from Winnipeg. There's icy roads everywhere. Do you see trends in sort of seasonality with some of these falls that we're seeing in the data?
Yeah, well, like you mentioned, falls in older adults, spikes in you know, January to March. But what's interesting is to understand that those falls are occurring within the home. You might think it's slippery surfaces, walking on sidewalks. Yes, they do occur. And yes, we do have a safer into walking campaign with Walk Like a Penguin and having that intergenerational approach to winter safety. But really, we also have our home safety checklist that we make readily available so that we know that we need to push it during that time of the year in order to empower our older adults so that they can take the right steps in order to make their home environment that much safer. Another use of data is looking at our road and trail safety awareness campaign that occur during the month of August, when we typically see the spikes in motor vehicle related injuries. So our awareness campaigns, we have 4 across the year. Again, we can't do a campaign for everything. So during the month of February is our winter safety campaign. May is our safe sports and recreation awareness campaign. August being our road and trail safety awareness campaign, and November being our falls prevention campaign. So we got the big 4, again, using data to help determine what are the priorities with limited resources and pairing it to the time of the years where we see the highest numbers.
Fabulous. Thank you so much. And thank you for all of your thoughtful responses, Dr. Lewis. I think that will conclude sort of the discussion period for your presentation. I'm going to pass it over to my co-pilot, Louisa, for closing remarks.
So we are approaching the end of today's seminar, and we would like to take this time to thank you, Dr. Richard, for sharing your insights and expertise in this topic. And of course, thanks to all of you for joining us today for the 5th seminar of the Surveillance Advances, and we hope you enjoyed this seminar. So please take some time to complete our survey for this presentation. You can scan the QR code on this slide to access the survey, or look for the link that we will share with you shortly. Your feedback is very important to help us to identify areas of success or improvement for this series. You will also be able to request a letter of participation at the end of the survey. Just a reminder that the recording for today's seminar and the presentation material will be accessible for viewing on the NCCID's website in a few weeks. And also, if you have more questions about the Surveillance Advances seminar series, please visit NCCID's website, which is nccid.ca. Our next seminar will be held on Tuesday, March 26th. So that concludes today's seminar, and thank you all for joining us, and see you next time. Thank you so much.